Physician Services. Appendix PP, Regulation Section 483.30, tags F710 through F715. Begin reading. Tag F710. Section 483.30, Physician Services. A physician must personally approve in writing a recommendation that an individual be admitted to a facility. Each resident must remain under the care of a physician, physician assistant, nurse practitioner, or clinical nurse. Specialist must provide orders for the resident's immediate care and needs. Section 483.30A, Physician Supervision. The facility must ensure that. Section 483.30A1, the medical care of each resident is supervised by a physician. Section 483.30A2, another physician supervises the medical care of residents when their attending physician is unavailable. Intent Section 483.30A. The intent of this regulation is to ensure the medical supervision of the care of each resident by a physician, and that orders for the resident's immediate care and needs are provided throughout the resident's stay. Definitions, Section 483.30A. Attending physician refers to the primary physician who is responsible for managing the resident's medical care. This does not include other physicians whom the resident may see periodically, such as specialists. Non-physician practitioner NPP is a nurse practitioner NP, clinical nurse. Specialist CNS, or physician assistant PA. Nurse practitioner is a registered professional nurse currently licensed to practice in the state and who meets the state's requirements governing the qualification of nurse practitioners. Clinical nurse specialist is a registered professional nurse currently licensed to practice in the state and who meets the state's requirements governing the qualifications of clinical nurse specialists. Physician assistant is a person who meets the applicable state requirements governing the qualifications for assistants to primary care physicians. Guidance Section 483.30A. A physician's personal approval of an admission recommendation must be in written form. The written recommendation for admission to the facility must be provided by a physician and cannot be provided by a NPP. This may be accomplished through a hospital transfer summary written by a physician, paperwork completed by the residents, physician in the community, or other written form by a physician. If a physician does not provide a written recommendation that the individual be admitted to the facility prior to the resident's admission, the physician's admission orders for the resident's immediate care as required in Section 483.20A will be accepted as personal approval of the admission if the orders are provided by a physician. Admission orders in lieu of a physician's written recommendation for admission to the facility cannot be provided by a NPP. Generally, the term attending physician or physician may also include a NPP involved in the management of the resident's care to the extent permitted by state law. However, when the regulation specifies a task to be completed personally by the physician, that task may not be delegated to a NPP. Supervising the medical care of residents means participating in the resident's assessment and care planning, monitoring changes in residents' medical status, and providing consultation or treatment when contacted by the facility. It also includes, but is not limited to, prescribing medications and therapy, ordering a resident's transfer to the hospital, conducting required routine visits or delegating to and supervising follow-up visits by NPPs. It is the responsibility of the facility to ensure that another physician supervises the care of residents when the attending physician is unavailable. The attending physician may Designate another physician to act on his or her behalf when unavailable. If the attending physician is unavailable and does not designate another physician to act on his or her behalf, or the designated physician is unavailable, the facility must have a physician available who will supervise the care of the attending physician's residents. There may be examples of physician orders in the medical record that would not impact a resident's medical care, such as instructions to contact a family member or providing date/time of an order. Concerns related to these types of orders do not fall under the category of a physician's supervision of medical care and would not be cited here. Probe Section 483.30a. Is there evidence that the attending physician supervises the resident's medical care? If not, what did the facility do? If the physician makes a change to the resident's plan of care, e.g. orders a new medication or changes a medication, is there evidence that the physician evaluated the effectiveness of the intervention and the resident's response? Note, the timing of the reevaluation may vary depending upon the type of change, type of medication. If staff reported a change in medical status to the physician, how did the physician respond? If the attending physician was unavailable and could not respond, did the facility have a physician available to supervise the medical care of the resident? How did this physician respond? When a NPP performs a delegate physician visit and determines that the resident's condition warrants direct contact between the physician and the resident, does the physician follow up promptly with a personal visit? Potential tags for additional investigation. The facility must ensure each resident has the right to designate an attending physician. For potential concerns related to the resident having the choice of attending physician who is able and willing to meet the physician services requirements, see Section 483.10d. F715 for additional guidance. For concerns related to admission orders, see Section 483.20a, F635. At the time each resident is admitted, the facility must have physician's orders for the resident's immediate care. For concerns related to physician availability for emergencies 24 hours a day, see Section 483.30d, F713. Deficiency Categorization Section 483.30a. Examples of Level 4. Immediate jeopardy to resident health and safety include, but are not limited to: the facility failed to ensure the physician conducted a medical evaluation of a resident with a new onset of seizures. As a result, anticonvulsant medications were prescribed, but the primary cause of the seizures was not evaluated to determine if it was neurological or secondary to another condition, such as infection or drug interaction. This placed the resident at risk for serious harm or deaths. The physician failed to provide laboratory orders for routine monitoring for a resident receiving anticoagulant medication, placing the resident at risk for significant adverse side effects, including the risk for serious injury or death, such as gastrointestinal bleeding or stroke. The facility failed to follow up with the physician regarding the absence of laboratory orders and administered the anticoagulant medication as ordered. An example of Level 3, actual harm that is not immediate jeopardy includes, but is not limited to: the facility failed to ensure the physician supervised the resident's medical care. When the physician did not evaluate the effectiveness of treatments ordered for a skin condition, resulting in the development of a localized skin infection causing significant pain for the resident. An example of Level 2, no actual harm, with potential for no more than minimal harm that is not immediate jeopardy includes, but is not limited to: the facility failed to follow up on recommendations from the dietitian for diet. Liberalization for a resident whose attending physician did not respond to phone calls. The facility then failed to contact another physician to assist with providing care for the resident when the facility was unable to reach the attending physician. An example of Level 1, no actual harm with potential for no more than a minor negative impact on the resident includes, but is not limited to, the failure of the facility to ensure a resident's medical care is supervised by a physician, or to ensure that the resident has orders for immediate care and needs. Always places the resident at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Tag F711. Section 483.30b, Physician Visits. The physician must. Section 483.30b1, review the resident's total program of care, including medications and treatments, at each visit required by paragraph C of this section. Section 483.30b2, write, sign, and date progress notes at each visit, and Section 483.30b3, sign and date all orders with the exception of influenza and pneumococcal vaccines, which may be administered per physician-approved facility. Policy after an assessment for contraindications. Intent Section 483.30b. The intent of this regulation is to have the physician take an active role in supervising the care of the residents. Physician visits should not be superficial visits, but must include an evaluation of the resident's condition and total program of care, including medications and treatments, and a decision about the continued appropriateness of the resident's current medical regimen. Guidance Section 483.30b. Except where the regulation specifies the task must be completed personally by the physician, the term attending physician or physician also includes a non-physician practitioner, NPP, involved in the management of the resident's care, to the extent permitted by state law. Total program of care includes all care the facility provides residents to maintain or improve their highest practicable physical, mental, and psychosocial well-being, as defined by the Comprehensive Assessment and Plan of Care. Care includes medical services and medication management, physical, occupational, and speech/language therapy, nursing care, nutritional interventions, social work and activity services that maintain or improve psychosocial functioning. During required visits, the physician must document a review of the resident's total program of care, including the resident's current condition, progress, and problems in maintaining or improving their physical, mental, and psychosocial well-being, and decisions about the continued appropriateness of the resident's current medical regimen. The physician need not review the total plan of care at each visit, but must review the total plan of care at visits required by Section 483.30c, F712. Progress notes must be written, signed, and dated at each physician visit, which may be done in a physical chart or electronic record, in keeping with facility practices. During visits, the physician must also sign and date all orders, with the exception of influenza and pneumococcal vaccinations, which may be administered per physician approved facility policy after an assessment for contraindications. This includes signing orders written by NPPs, qualified dietitians, other clinically qualified nutrition professionals, and qualified therapists, as required by state law. In cases where facilities have created the option for a resident's record to be maintained by computer rather than hard copy, electronic signatures are acceptable. See guidelines for Section 483.70H1, F842, For information on facility safeguards concerning electronic signatures, physician orders may be transmitted by facsimile machine if the following conditions are met. The physician should have signed and retained the original order from which the facsimile was transmitted and be able to provide it upon request. Alternatively, the original may be sent to the facility at a later time and substituted for the facsimile. The facility should photocopy the faxed order if the faxed order is subject to fading over time. The facsimile copy can be discarded after facility photocopies it. It is not necessary for a physician to re-sign the facsimile order when he/she visits the facility. When rubber stamp signatures are authorized by the facility's management, the individual whose signature the stamp represents shall place in the administrative offices of the facility a signed statement to the effect that he/she is the only one who has the stamp and uses it, a list of computer codes, identification numbers, and / or written signatures must be readily available and maintained under adequate safeguards. Adequate safeguards may include, but are not limited to, locked in a drawer, locked in a location that is accessible only by appropriate staff as defined by the facility, or available on a protected electronic site accessible by appropriate staff as defined by the facility. Probes Section 483.30b. Are physician progress notes written, signed, and dated during each physician visit? For visits required by Section 483.30c, do physician progress notes reflect a review of the resident's total program of care and current condition, including medications and treatments? Do physician progress notes reflect the physician's decisions about the continued appropriateness of the resident's current medical regimen? Does the physician sign and date all physician orders during visits with the exception of influenza and pneumococcal vaccines, as outlined above? If the physician has not met the requirements of physician visits, how has the facility worked with the physician or sought alternate physician participation to assure that the resident receives appropriate care and treatment? If facility management allows for the use of rubber stamp signatures, are adequate safeguards in place to ensure the security of the stamps? Potential tags for additional investigation. If concerns regarding physician supervision of the resident's care are identified, investigate Section 483.30a, F710. For concerns related to admission orders, see Section 483.20a, F635. For concerns related to the frequency of physician visits, see Section 483.30c, F712. For concerns related to the medical director's follow-up on clinical issues or physician activities, see Section 483.70g, F841. Deficiency Categorization Section 483.30b. Examples of Level 4, immediate jeopardy to resident health and safety, include, but are not limited to: after a recent hospitalization, the facility failed to ensure the attending physician reviewed the hospital discharge summary or hospital progress notes. This lack of review of the resident's total program of care, including medications and treatments, resulted in the resident not receiving orders for new medications essential to the resident's medical treatment. As a result of the lack of essential medications, serious harm or death occurred or was likely to occur. Facility staff contacted the physician on multiple occasions regarding the resident's elevated blood sugar levels. During a visit, the physician did not review the resident's recorded blood sugar values or talk to the nurse regarding the resident's status or order changes to the resident's treatment regimen. The Facility's failure to intervene when the physician was on-site or to seek alternate intervention resulted in the resident experiencing diabetic ketoacidosis, which required hospitalization for management. Example of Level 3. Actual harm that is not immediate jeopardy includes, but is not limited to. The facility failed to ensure the physician completed a medical evaluation of a resident's condition and review the appropriateness of the resident's medical regimen, specifically a resident who had executed a living will at a time when he had capacity, indicated that it was his desire to refuse any treatment other than comfort measures in the event of an irreversible terminal illness from which there was no hope of recovery, despite documentation from the pulmonologist that there was no expectation that the resident could survive without artificial means. And contrary to the resident's wishes, the attending physician ordered, and the facility provided, aggressive, life-sustaining treatment including artificial ventilation and feeding. As a result, the resident received unwanted treatment in the facility. Examples of Level 2, no actual harm, with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. While the physician reviewed areas identified as high priority for the physician to address in the resident's program of care, the facility failed to ensure the physician reviewed the resident's total program of care or wrote, signed and dated progress notes with each visit. The facility failed to ensure physician progress notes that documented the physician's involvement in the assessment and care of residents were completed as required. Example of Level 1, no actual harm with potential for no more than a minor negative impact on the resident includes, but is not limited to. During a physician visit, the physician failed to sign and date new orders. However, the orders were followed as intended, and no adverse outcome was experienced by the resident. Tag F712. Section 483.3, 0C frequency of physician visits. Section 483.3, 0C1, the resident must be seen by a physician at least once every 30 days. For the first 90 days after admission, and at least once every 60 days thereafter. Section 483.3, 0C2, a physician visit is considered timely if it occurs not later than 10 days after the date the visit was required. Section 483.30C3, except as provided in paragraphs C4 and F of this section, all require physician visits must be made by the physician personally. Definitions, Section 483.30C. Must be seen, for purposes of the visits required by Section 483.30C1, means that the physician or NPP must make actual face-to-face contact with the resident, and at the same physical location, not via a telehealth arrangement. There is no requirement for this type of contact at the time of admission, since the decision to admit an individual to a nursing facility, whether from a hospital or from the individual's own residence, generally involves physician contact during the period immediately preceding the admission. Non-physician practitioner NPP means a nurse practitioner NP, clinical nurse, specialist CNS, or physician assistant PA. Guidance section 483.30C. The timing of physician visits is based on the admission date of the resident. In a SNF, the first physician visit, this includes the initial comprehensive visit, must be conducted within the first 30 days after admission, and then at 30-day intervals up until 90 days after the admission date. After the first 90 days, visits must be conducted at least once every 60 days thereafter. Permitting up to 10 days slippage of a due date will not affect the next due date. However, Do not specifically look at the timetables for physician visits unless there is indication of inadequate medical care. The regulation states that the physician, his or her delegate, must visit the resident at least every 30 or 60 days. There is no provision for physicians to use discretion in visiting at intervals longer than those specified at Section 483.30C, F712. Although the physician may not delegate the responsibility for conducting the initial visit in a SNF, NPPs may perform other medically necessary visits prior to and after the physician's initial visit, as allowed by state law. After the initial physician visit in SNFs, where states allow their use, an NPP may make every other required visit. See Section 483.30E, F714 Physician Delegation of Tasks in SNFs. These alternate visits, as well as medically necessary visits, may be performed and signed by the NPP. Physician co-signature is not required unless required by state law. In a NF, the physician visit requirement may be satisfied in accordance with state law by an NPP who is not an employee of the facility, but who is working in collaboration with a physician and who is licensed by the state and performing within the state's scope of practice. See Section 483.30F. In a NF, medically necessary visits performed by NPPs employed by the facility may not take the place of physician-required visits, nor may the visit count towards meeting the physician visit schedule prescribed at Section 483.20C1. In SNFs and NFs, facility policy that allows NPPs to conduct required visits and or allows a 10-day slippage in the time of the required visit does not relieve the physician of the obligation to visit a resident personally when the resident's medical condition makes that visit necessary. Table 1. Authority for non-physician practitioners to perform visits, sign orders, and sign Medicare Part A certifications/recertifications when permitted by the state. Initial admission, other certifications/ comprehensive orders * required medically recertification. Visits and necessary. Visit orders, visits and orders plus. SNFs. PA, NP and may perform. CNS may not perform, may not alternate, may perform, may not sign. Employed by provide visits and ensign. Sign. The facility. PA, NP, and may not perform, may not, may perform, may sign as. CNS, not a provide, perform, and sign permitted under facility, alternate state laws. Employee visits and sign. NFs. May not perform, may perform, not applicable. PA, NP, and provide, perform, or ensign. CNS sign. Employed by the may perform, may provide *, may perform, not applicable. Facility and sign. PA, NP and CNS nada. Facility. Employee. * a NPP may provide admission orders if a physician personally approved in writing a recommendation for admission to the facility prior to the resident's admission. 4. Additional requirements on physician recommendation for admission and admission orders, see Section 483.30A, F710. Other required visits are the physician visits required by Section 483.30C1 other than the initial comprehensive visit. Plus medically necessary visits are independent of required physician visits Section 483.30C1 and may be performed prior to the initial comprehensive visit as permitted under state laws. Though not part of a compliance determination for this section, this column is provided for clarification and relates specifically to coverage of a Medicare stay. Requirements, which can take place only in a Medicare-certified SNF. In a facility where beds are duly certified under Medicare and Medicaid, the facility must determine how the particular resident's stay is being paid in order to identify whether physician delegation of tasks is permissible and if an NPP may perform the tasks. For example, for residents in a Medicare stay, the NPP must follow the requirements. For physician services in a SNF, this includes, at the option of a physician, required physician visits alternated between personal visits by the physician and visits by an NPP after the physician makes the initial comprehensive visit, and for residents in a Medicaid stay, the NPP must follow the requirements for physician services in a NF. An NPP who is not employed by the facility and is working in collaboration with a physician may perform any required physician task for a resident in a Medicaid stay at the option of the state. NPPs employed by the facility may not perform required physician visits, but may perform other medically necessary visits. It is expected that visits will occur at the facility rather than the doctor's office unless office equipment is needed or a resident specifically requests an office visit. If the facility has established policy that residents leave the grounds for medical care, the resident does not object, and this policy does not infringe on his or her rights, including the right to privacy. There is no prohibition to this practice. The facility should inform the resident of this practice in accordance with Section 483.10 G16, F715, Notice of Rights and Services, Certifications/recertifications in SNFs. Under 42 CFR Section 424.20, certifications and certifications are required to verify that a resident requires daily skilled nursing care or rehabilitation services. NPs, CNSs, and PAs who are not employed by the facility and who are working in collaboration with a physician may sign the required initial certification and recertifications when permitted under the scope of practice for the state. 42 CFR Section 424.20E2. Probes Section 483.30C. Does the scheduling and frequency of physician visits relate to any identified quality of care problems? If the resident is admitted under a SNF stay, did the physician conduct the initial comprehensive visit in person within the first 30 days? If the resident is admitted under a NF stay, did the physician or an NPP who is not employed by the facility, but who is working in collaboration with a physician conduct the initial comprehensive visit in person within the first 30 days? Are physician visits conducted at the required intervals with no more than 10 days slippage from the due date? In a SNF, if the physician delegates required visits to an NPP, does the physician personally conduct alternate visits with the NPP as required? Does the resident or resident representative report meeting with the physician? If so, how often? Potential tags for additional investigation. If the failure of the physician to visit the resident at the required intervals resulted in a negative outcome to the resident, also investigate compliance with Section 483.30A, F710. Residence care supervised by a physician. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health and safety, includes, but is not limited to, the facility failed to ensure the attending physician conducted required visits for several consecutive months in the facility. The physician responded to phone calls and provided verbal orders during this time frame, however did not visit and make face-to-face contact with the resident who experienced a Significant negative change in status. No other physicians or NPPs visited the resident. This placed the resident at risk for serious harm or death. An example of Level 3, actual harm that is not immediate jeopardy, includes, but is not limited to, a resident newly admitted to the facility and determined to be at high risk of developing a pressure ulcer/injury, developed an unstageable pressure ulcer. During the first 30 days, while the physician was consulted by telephone, the facility failed to ensure the physician conducted an initial comprehensive visit for over 40 days, contributing to the decline in the resident's skin status. Examples of Level 2, no actual harm, with potential for more than minimal harm that is not immediate jeopardy, includes, but is not limited to, the facility failed to ensure the physician personally conducted an initial comprehensive visit within the first 30 days after admission for a resident under a Medicare Part A stay. An example of Level 1, no actual harm with potential for no more than a minor negative impact on the resident, includes, but is not limited to, the facility failed to ensure that the attending physician alternated required monthly visits with the nurse practitioner, NP, as required for a resident under a SNF stay. A review of the progress notes revealed that notes were written, signed and dated by the NP for several consecutive visits, and all of the resident's needs were met. No documentation was found to indicate that the attending physician had visited and examined the resident at least once every 30 days for the first 90 days after admission, or at least once every 60 days thereafter during this time. Tag F713. Section 483.30D. Availability of physicians for emergency care. The facility must provide or arrange for the provision of physician services 24 hours a day in case of emergency. Guidance Section 483.30D. If a resident's attending physician is unavailable, the facility should attempt to contact the physician covering for the attending physician before assuming the responsibility of contacting another physician. Arranging for physician services may include assuring resident transportation to a hospital emergency room or other medical facility if the facility is unable to meet the particular medical need at the facility. The provision of transportation does not remove the facility's responsibility to have a physician available 24 hours a day to respond to emergencies that do not require medical care in an alternative setting. Probes Section 483.30D. Does the facility have a physician on call for medical emergencies? Does this physician respond? In emergency situations, are residents unnecessarily sent to hospital emergency rooms due to the lack of physician availability or inability to contact a physician? Consider whether the resident's needs could have been met in the facility had the facility had a physician available. If the facility did not arrange for the provision of physician services 24 hours a day for emergencies, what was the impact on residents? Deficiency Categorization Section 483.30C. Example of Level 4, immediate jeopardy to resident health and safety, includes, but is not limited to, the attending physician, who was the only physician of the facility, and the medical director failed to have an alternate physician or non-physician practitioner available for the residents in case of an emergency. When he left the country, the facility did not have an agreement with another physician to provide physician services in the absence of the attending physician. When a resident with a known history of congestive heart failure developed edema in the lower extremities, the facility did not have a physician to contact for consultation and new orders for interventions, resulting in hospitalization of the resident. Example of Level 3. Actual harm that is not immediate jeopardy includes, but is not limited to. The facility received laboratory results indicating that a resident had a urinary tract infection UTI. Attempts to contact the attending physician were unsuccessful, and the facility did not have an alternate physician on call for emergencies. The facility did not secure timely medical treatment at the local hospital or alternate medical facility for the resident, resulting in progression of the infection before interventions were implemented. Example of Level 2. No actual harm, with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to. The facility failed to ensure the physician responded promptly to notification of a resident's fall. Phone calls from the licensed nurses about the fall and the swelling of the left ankle were not returned for 24 hours, and the facility did not secure alternate medical intervention for the resident during this time. Example of Level 1. No actual harm with potential for no more than a minor negative impact on the resident includes, but is not limited to. The failure of the facility to provide physician services 24 hours a day, in case of an emergency, places the resident at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Tag F714. Section 483.30e. Physician delegation of tasks in SNFs. Section 483.30e1. Except as specified in paragraph E4 of this section, a physician may delegate tasks to a physician assistant, nurse practitioner, or clinical nurse specialist who I meets the applicable definition in Section 491.2 of this chapter, or, in the case of a clinical nurse specialist, is licensed as such by the state. Roman II is acting within the scope of practice as defined by state law, and Roman III is under the supervision of the physician. Section 483.30e4. A physician may not delegate a task when the regulations specify that the physician must perform it personally, or when the delegation is prohibited under state law or by the facility's own policies. Section 483.30f. Performance of physician tasks in NFs. At the option of state, any required physician task in a NF, including tasks which the regulations specify must be performed personally by the physician, may also be satisfied when performed by a nurse practitioner, clinical nurse specialist, or physician assistant who is not an employee of the facility but who is working in collaboration with a physician. Intent Section 483.30e1 and 4. To allow the physician, under certain conditions, to delegate tasks to a nurse practitioner, clinical nurse specialist, or physician assistant working under the physician's supervision. Definitions, Section 483.30e1 and 4. Clinical nurse specialist is a registered professional nurse currently licensed to practice in the state and who meets the state's requirements governing the qualifications of clinical nurse specialists. Nurse practitioner is a registered professional nurse who is currently licensed to practice in the state, who meets the state's requirements governing the qualification of nurse practitioners and who meets one of the following conditions. 1 is currently certified as a primary care nurse practitioner by the American Nurses Association or by the National Board of Pediatric Nurse Practitioners and Associates, or 2 has satisfactorily completed a formal 1 academic year educational program that prepares registered nurses to perform an expanded role in the delivery of primary care. Roman II includes at least 4 months in the aggregate of classroom instruction and a component of supervised clinical practice. And Roman 3 awards a degree, diploma, or certificate to persons who successfully complete the program, or 3 has successfully completed a formal educational program for preparing registered nurses to perform an expanded role in the delivery of primary care that does not meet the requirements above and has been performing an expanded role in the delivery of primary care for a total of 12 months during the 18-month period immediately preceding September 22, 2006. Physician assistant is a person who meets the applicable state requirements governing the qualifications for assistants to primary care physicians and who meets at least one of the following conditions. 1 is currently certified by the National Commission on Certification of Physician Assistants to assist primary care physicians, or 2 has satisfactorily completed a program for preparing physicians' assistants that was at least 1 academic year in length. Roman 2 consisted of supervised clinical practice and at least 4 months in the aggregate of classroom instruction directed toward preparing students to deliver health care, and Roman 3 was accredited by the American Medical Association's Committee on Allied Health Education and Accreditation, or 3 has satisfactorily completed a formal educational program for preparing physician assistants that does not meet the requirements above and has been assisting physicians for a total of 12 months during the 18-month period that ended on December 31, 1986. Non-physician practitioner NPP is a nurse practitioner NP, clinical nurse, specialist CNS, or physician assistant PAR as defined above. Guidance section 483.30E1 and 4. The extent to which physician services may be delegated to NPPs and SNFs is governed by the provisions of Section 483.30E, while the extent to which these services may be performed by NPPs and NFs is governed by the provisions of Section 483.30F. Refer to table in F712. In SNFs, when personal performance of a particular task by a physician is specified in the regulations, performance of that task cannot be delegated to anyone else. The tasks of examining the resident, reviewing the resident's total program of care, writing progress notes, and signing orders may be delegated, unless prohibited by state law or facility policies. Probes section 483.30E1 and 4. Do the attending physicians delegate tasks to NPPs? If the physician delegates tasks to NPs or PAs, does the NP or PA meet the requirements in section 491.2? If the physician delegates tasks to CNSs, is the CNS licensed as such by the state? Do NPPs follow the scope of practice allowed by state law in conducting examinations, evaluations, writing progress notes, and orders? Does the physician supervise the NPP in the SNF? Examples of supervision may include face-to-face encounters, clinical record reviews, telephone consults, mail, telehealth, and electronic health records. Definitions, section 483.30F. Collaboration is a process often governed by the laws of a given state in which a non-physician practitioner, NPP, works with one or more physicians to deliver health care services within the scope of the NPP's expertise, with medical direction and appropriate supervision, as provided for in jointly developed guidelines or other mechanisms. In the absence of state law governing collaboration, such collaboration is to be evidenced by NPPs, documenting the NPP's scope of practice and indicating the relationships that they have with physicians to deal with issues outside their scope of practice. The collaborating physician does not need to be present with the NPP when the services are furnished or to make an independent evaluation of each resident who is seen by the NPP. Guidance Section 483.30F. At the option of the state, NPPs and NF, who are not employees of the facility, may perform physician tasks including performing examinations, evaluations, required visits, and writing orders. If the physician delegates the task of performing visits to the NPP must meet all of the requirements for Section 483.30A, F710, Physician Supervision. Section 483.30B, F711, Physician Visits. Section 483.30C, F712, Physician Frequency and Timeliness of Visits. Note, if concerns are identified regarding the NPP meeting the requirements for physician supervision, physician visits, or frequency and timeliness of visits, investigate under the corresponding regulation. Orders written by a NPP who is employed by the NF and are written during visits that are not required visits and are therefore other medically necessary visits, do not require physician co-signature, except as mandated by state law. Probes, Section 483.30F. If the physician delegates the performance of required physician tasks to the NPP. In the NF, is the delegation allowed by the state? When performing physician tasks in the NF, is the NPP functioning within their scope of practice as permitted in their state? If a NPP is performing required physician visits in the NF, is the NPP an employee of the facility? Facility employees are prohibited from serving in this capacity. How does the facility ensure the NPP is working in collaboration with the physician? Tag F715. Section 483.30E2. A residence attending physician may delegate the task of writing dietary orders, consistent with Section 483.60, to a qualified dietitian or other clinically qualified nutrition professional who I is acting within the scope of practice as defined by state law, and Roman II is under the supervision of the physician. Section 483.30E3. A residence attending physician may delegate the task of writing therapy orders, consistent with Section 483.65, to a qualified therapist who I is acting within the scope of practice as defined by state law, and Roman II is under the supervision of the physician. Intent Section 483.30E23. To provide physicians with the flexibility to delegate to a qualified dietitian/other clinically qualified nutrition professional the task of writing dietary orders, and 2. Delegate to a qualified therapist the task of writing therapy orders. This flexibility is beneficial to the physician and the resident, allowing the physician to determine how to best use his or her time, and allowing the resident to have more frequent adjustments to nutritional needs and therapy as his or her condition or abilities change. Definitions, Section 483.30E23. Qualified dietitian is defined in Section 483.60 as follows. Section 483.60A1. A qualified dietitian or other clinically qualified nutrition professional, either full-time, part-time, or on a consultant basis. A qualified dietitian or other clinically qualified nutrition professional is one who I holds a bachelor's or higher degree granted by a regionally accredited college, university in the United States, or an equivalent foreign degree with completion of the academic requirements of a program in nutrition or dietetics, accredited by an appropriate national accreditation organization recognized for this purpose. Roman II has completed at least 900 hours of supervised dietetics practice under the supervision of a registered dietitian or nutrition professional. Roman 3 is licensed or certified as a dietitian or nutrition professional by the state in which the services are performed. In a state that does not provide for licensure or certification, the individual will be deemed to have met this requirement if he or she is recognized as a registered dietitian by the Commission on Dietetic Registration or its successor organization, or meets the requirements of paragraphs A1I and Roman 2 of this section. Roman 4, for dietitians hired or contracted with prior to November 28, 2016, meets these requirements no later than 5 years after November 28, 2016, or as required by state law. Qualified therapist, professional staff, licensed, certified, or registered to provide specialized therapy/rehabilitative services in accordance with state laws, includes physical, occupational, and respiratory therapists and speech-language pathologists. Guidance Section 483.30E23. Physicians and NPPs may delegate the task of writing orders to qualified dietitians or clinically qualified nutrition professionals and qualified therapists if the State Practice Act allows the delegation of the task, and the State Practice Act for the qualified individual being delegated the task of writing orders permits such performance. Delegation of this task does not relieve the physician of the obligation to supervise the medical care of his or her residents. Physician responsibilities related to physician supervision of resident care are located in Section 483.30A, F710, and physician obligations for conducting resident visits are located at Section 483.30B, F711. Dietary orders written by a qualified dietitian/clinically qualified nutritional professional or therapy orders written by therapists do not require physician co-signature, except as required by state law. Probes 483.30E23. If the dietitian/other clinically qualified nutrition professional is writing dietary orders or a qualified therapist is writing therapy orders, did the attending physician delegate this task? If state law allows dietitians or other clinically qualified nutrition professionals to write dietary orders, are they functioning within the scope of practice defined by state law? If state law allows therapists to write therapy orders, are they functioning within the scope of practice defined by state law? Do physicians co-assign dietitian/other clinically qualified nutrition professional orders and /or therapist orders, if required by state law? Is there evidence of physician supervision of dietitians/other clinically qualified nutritional professionals and /or qualified therapists who write orders? Examples of supervision may include face-to-face encounters, clinical record reviews, telephone consults, email, telehealth, and electronic health records. When facility policy and state law allows physicians to delegate the task of writing orders to qualified dietitians, other clinically qualified nutrition professionals, and qualified therapists, how does the facility ensure the physician supervision of individuals performing these tasks? Section 483.35, Nursing Services. The facility must have sufficient nursing staff with the appropriate competencies and skills sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnoses of the facility's resident population in accordance with the facility assessment required at Section 483.71. Always review nursing services requirements under Section 483.3(5) during a standard or extended survey when a waiver of RN and / or licensed nurse RN/LPN staffing has been requested or granted, or if a complaint has been received regarding nursing services. If the survey investigation reveals that there are not sufficient or competent staff, refer to F725 or 726, Section 483.3(5)(a), C for any nursing services not related to behavioral health care or dementia care. F741, Section 483.40(a) for any staff caring for residents with dementia or a history of trauma and / or post-traumatic stress disorder. F801, Section 483.60(a) for food and nutrition staff. F826, Section 483.65(b), specialized rehabilitative services. F839, Section 483.70(e), administration for any other staff not referenced above. Potential requirements for additional investigation. If noncompliance with Section 483.35 has been identified, the surveyor may have identified concerns with related structure, process, and / or outcome requirements. If any additional concerns have been identified, the surveyor must investigate the identified concern. Do not cite any related or associated requirements before first investigating to determine compliance or noncompliance with the related or associated requirement. Examples include, but are not limited to, the following: freedom from abuse, neglect, and exploitation, Section 483.12. Quality of life, Section 483.24. Quality of care, Section 483.25. Behavioral health services, Section 483.40. Administration, Section 483.70. Staff qualifications, Section 483.70(e), or use of outside resources, Section 483.70(f). Section 483.7(1), facility assessment. Quality assurance and performance improvement, Section 483.75. Training, Section 483.95. Tag F725. Section 483.35, nursing services. The facility must have sufficient nursing staff with the appropriate competencies and skills sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnosis of the facility's resident population in accordance with the facility assessment required at Section 483.71. Section 483.3, 5A, sufficient staff. Section 483.3, 5A1. The facility must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to all residents in accordance with resident care plans. I, except when waived under paragraph E of this section, licensed nurses, and Roman II, other nursing personnel, including but not limited to nurse aides. Section 483.3, 5A2, except when waived under paragraph E of this section, the facility must designate a licensed nurse to serve as a charge nurse on each tour of duty. Intent, Section 483.3, 5A12. To assure that there is sufficient qualified nursing staff available at all times to provide nursing and related services to meet the residents' needs safely and in a manner that promotes each resident's rights, physical, mental, and psychosocial well-being. Definitions, Section 483.3, 5A12. Nurse aide, as defined in Section 483.5, is any individual providing nursing or nursing related services to residents in a facility. This term may also include an individual who provides these services through an agency or under a contract with the facility, but is not a licensed health professional, a registered dietitian, or someone who volunteers to provide such services without pay. Nurse aides do not include those individuals who furnish services to residents only as paid feeding assistants, as defined in Section 488.301. Guidance Section 483.3, 5A12. Note: cite this tag only if there are deficiencies related to the sufficiency of nursing staff. If the survey investigation reveals that there are not sufficient staff in areas other than nursing services, refer to F741, Section 483.40A for any staff caring for residents with dementia or a history of trauma and or post-traumatic stress disorder. F801, Section 483.60A for food and nutrition staff. F826, Section 483.6, 5B for specialized rehabilitative services, and F839, Section 483.70E for administration for any other staff not referenced above. Note: the actual or potential physical, mental, or psychosocial resident outcomes related to noncompliance cited at F725 should be investigated at the relevant tags, such as abuse at Section 483.12, quality of life at Section 483.24, and or quality of care at Section 483.25. Many factors must be considered when determining whether or not a facility has sufficient nursing staff to care for residents' needs, as identified through the facility assessment, resident assessments, and as described in their plan of care. A staffing deficiency under this requirement may or may not be directly related to an adverse outcome to a resident's care or services. It may also include the potential for physical or psychosocial harm, as required under administration at F838, Section 483.71, an assessment of the resident population is the foundation of the facility assessment and determination of the level of sufficient staff needed. It must include an evaluation of diseases, conditions, physical or cognitive limitations of the resident populations, acuity, the level of severity of residents' illnesses, physical, mental, and cognitive limitations and conditions, and any other pertinent information about the residents that may affect the services the facility must provide. The assessment of the resident population should drive staffing decisions and inform the facility about what skills and competencies staff must possess in order to deliver the necessary care required by the residents being served. Procedure, Section 483.3, 5A12. Although federal regulations do not define minimum nursing staff ratios, many states do. If a facility does not meet state regulations for staffing, do not cite that as a deficiency here, but refer to administration, F836, Section 483.70B. In addition, even if a facility meets the state staffing regulations, that is not, by itself, sufficient to demonstrate that the facility has sufficient staff to care for its residents. Compliance with state staffing standards is not necessarily determinative of compliance with federal staffing standards that require a sufficient number of staff to meet all of the residents' basic and individualized care needs. a facility may meet a state's minimum staffing ratio requirement and still need more staff to meet the needs of its residents. Additionally, the facility is required to provide licensed nursing staff 24 hours a day, 7 days a week. Surveyors must determine through information obtained by observations, interviews, and verified by record reviews whether the facility employed sufficient staff to provide care and services in assisting residents to attain or maintain their highest practicable level of physical, mental, and psychosocial well-being. The facility is responsible for submitting staffing data through the CMS payroll-based journal PBJ system. Refer to F715. Section 483.70p. This data can be obtained through the certification and survey provider. Enhanced Reports Casper reporting system. This PBJ staffing data report contains information about overall direct care staffing levels, including nurse staffing. Surveyors will utilize the PBJ staffing data report available through Casper reporting system to identify concerns with staffing. The Long-Term Care Survey Process LTCSB software application will alert the surveyors of specific dates that require further investigation. Related to staffing, surveyors are expected to verify infraction dates indicated on the PBJ staffing data report if concerns were identified on this report as well as from other sources. Refer to the critical element pathway of sufficient and competent staffing and the probes noted below. Probes. When interviewing staff, residents, and others, are concerns raised with the amount of time staff are available to provide care and services, such that there is not sufficient time allowed to provide the necessary care and services to a resident. If so, verify these concerns through observations and record review if necessary. Does the facility assessment describe the type and level of staff required to meet each resident's needs as assessed under Section 483.71? Does the type and level of the staff on-site reflect the expectations described in the facility assessment? Does the workload or assignments of the nursing staff allow them time to participate in team meetings, care planning meetings, attend training, spend time caring for residents, and take time for breaks including meal breaks? Are the numbers of licensed staff sufficient such that those staff members have enough time to provide direct services to residents as well as to assist and monitor all of the aides they are responsible for supervising? Do residents and families report that nursing staff are responsive to residents' request for assistance, such as call bells typically answered promptly? Do they feel that they can have a conversation with a direct caregiver and not feel rushed? Are there any indications of delays in responsiveness for staff, such as pungent odors, residents calling out, or residents wandering with inadequate supervision? Are there any indications of inappropriate use of devices or practices to manage residents' behaviors or activities that may suggest facility staff are using these devices or practices to compensate for lack of sufficient staff? Examples include high numbers and / or inappropriate use of position change alarms, positioning residents in chairs that limit their movement, or residents who are subdued or sedated. Are residents who are unable to use call bells or otherwise communicate their needs checked frequently, e.g., each half hour for safety, comfort, bathroom needs positioning, and offered fluids and other provisions of care? Have care problems associated with a specific unit, day, or tour of duty been identified by the facility? For example, does documentation show that skin integrity issues are identified more on days following a long weekend? Does the facility have adequate staff to monitor residents at risk for wandering? Has the use of overtime hours increased? if overtime hours have increased. Substantially, it can indicate that there is not sufficient staff or a backup plan. When staff call out. When there are staff call-outs, did the facility fill those positions in a timely manner? Does the facility have licensed nursing staff 24 hours a day? If the surveyor is made aware of the absences of licensed nursing staff in a 24-hour period. Interview direct care staff. Are you ever made aware of the absence of licensed nursing staff during your shift? When was the last time that licensed staff was not available during your shift? How often does this occur? How does this impact residents in the facility? Are you aware of any residents that missed medications or treatments due to no available licensed nurse? Who do you notify in the event of an emergency and there is no licensed nurses available? Interview the director of nursing or administrator. When was the last time that licensed nursing staff were not available on a shift? How often does the facility not have licensed nursing staff at all times? What is the facility's policy when there is not a licensed nurse available in a 24-hour period? How does the facility provide care to residents that require a licensed nurse if one is not available to work? How does this impact residents in the facility? Concerns such as falls, weight loss, dehydration, pressure ulcers, as well as the incidence of elopement and resident altercations can also offer insight into the sufficiency of the numbers of staff. Surveyors must investigate if these adverse outcomes are related to sufficient staffing. Key elements of noncompliance. To cite deficient practice at F725, the surveyor's investigation will generally show that the facility failed to do any one of the following. Ensure there are a sufficient number of skilled licensed nurses, nurse aides, and other nursing personnel to provide care and respond to each resident's basic needs and individual needs as required by the resident's diagnosis, medical condition, or plan of care, or ensure licensed nurse coverage 24 hours a day except when waived, or ensure a licensed nurse is designated to serve as a charge nurse on each tour of duty except when waived. Deficiency categorization. Once the survey team has completed its investigation, analyzed the data, reviewed the regulatory requirements, and determined that noncompliance exists, the team must determine the severity of each deficiency based on the harm or potential for harm to the resident. An example of Level 4, immediate jeopardy to resident health and safety includes, but is not limited to, a resident with a Stage 4 pressure injury did not receive skin assessments and treatments for 2 weeks due to the absence of the only trained wound nurse on the resident's scheduled skin assessment days. No accommodations were made for coverage in the absence of this wound nurse, and no other nursing staff were trained to provide this care. The pressure injury became infected during this time frame and resulted in the resident being hospitalized, requiring Roman 4 antibiotics. For sepsis, failure to provide sufficient staff with the necessary skill set to provide skin assessments and treatments created the likelihood for serious injury, harm, impairment, or death for the resident. A resident had complained of chest pain and shortness of breath after eating their evening meal. The nursing assistant stated they would inform the licensed nurse. The nursing assistant was informed there would be no licensed nurse available on site. At 10:00 p.m., the resident was found unresponsive with minimal respirations. Because there was no licensed nurse on duty at that time, the nursing assistant called 911, and the resident was sent to the emergency room. The survey team was made aware the facility had 4 days in the previous quarter of PBJ submission when there were no licensed nurses in the facility for all 24 hours. of each day. After a thorough investigation, the team determined the absences of a licensed nurse in the facility created the likelihood for serious injury, harm, impairment, or death for all residents. Examples of Level 3. Actual harm, physical or psychosocial, that is not immediate. Jeopardy includes, but are not limited to, a resident's room has a strong smell of urine. Upon further investigation, the surveyor discovers the resident is incontinent and has soiled undergarments. Upon interview, the resident stated he called for help about an hour ago and was told by staff that they were short-staffed today and would get to him as soon as they could. He also mentioned that this happens almost every day and he is embarrassed to ask staff for help to clean himself up, so he remains withdrawn in his room until a staff member can assist him. Refer to the psychosocial outcome guide for additional direction. A resident was admitted to the facility with a recently repaired hip fracture and required assistance with ambulation. The resident used the calling device to request assistance to the bathroom. After several minutes, no help arrived, so the resident attempted to ambulate with a walker to the bathroom without assistance. The resident subsequently fell and was found by nursing assistants. The resident was assisted back to bed by the nursing assistants and complained of pain in the area of the recently repaired hip fracture. There was no licensed nurse on duty to assess the resident for any injuries or provide medication for pain. The next morning, the resident complained of increased pain in the area of the repaired hip fracture. After assessment by the day shift licensed nurse, the resident was sent to the hospital. The resident was admitted and required surgery to repair the fractured hip. Examples of Level 2. No actual harm, with potential for more than minimal harm. That is not immediate jeopardy includes, but are not limited to. A resident's family complained that their loved one's personal hygiene was never completed in a timely manner due to lack of staff. When interviewed, staff stated that they typically assist this resident once the care is completed for all other residents in their assignment, since it takes longer to provide care for him. This resulted in the resident occasionally missing occupational therapy. There has been no recent documented decline in ADL function, but there is a potential for decline. Residents complain that they are not allowed choices, such as receiving showers consistently on the days, or at times they prefer due to inadequate staffing. Review of staffing data submitted via the PBJ system revealed the facility had a 1-star staffing quality rating. Follow-up interviews with the staffing coordinator revealed that only one CNA was available to provide showers, and therefore residents' preferences for timing of showering could not be met, cause anxiety. Refer to the Psychosocial Outcome Guide for additional direction. Severity Level 1. No actual harm with potential for minimal harm. The failure of the facility to provide sufficient staffing, including licensed nurses, creates a risk that is more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Tag F726. Section 483.35, Nursing Services. The facility must have sufficient nursing staff with the appropriate competencies and skills sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnoses of the facility's resident population in accordance with the facility assessment required at Section 483.71. Section 483.3, 5A3, the facility must ensure that licensed nurses have the specific competencies and skill sets necessary to care for residents' needs, as identified through resident assessments and described in the plan of care. Section 483.3, 5A4 providing care includes, but is not limited to assessing, evaluating, planning and implementing resident care plans, and responding to residents' needs. Section 483.3, 5C proficiency of nurse aides. The facility must ensure that nurse aides are able to demonstrate competency in skills and techniques necessary to care for residents' needs, as identified through resident assessments and described in the plan of care. Intent Section 483.3, 5A34, C. To assure that all nursing staff possess the competencies and skill sets necessary to provide nursing and related services to meet the residents' needs safely and in a manner that promotes each resident's rights, physical, mental, and psychosocial well-being. Definitions, Section 483.35. Competency is a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics that an individual needs to perform work roles or occupational functions successfully. Guidance Section 483.3, 5A34, C. Cite this tag only if there are deficiencies related to the competency of nursing staff. If the survey investigation reveals that there are concerns with the competency of staff in areas other than nursing services, refer to F741, Section 483.40A for any staff caring for residents with dementia or a history of trauma and or post-traumatic stress disorder. F801, Section 483.60A for food and nutrition staff. F826, Section 483.65B, specialized rehabilitative services. F839, Section 483.70E, administration for any other staff not referenced above. Note, the actual or potential physical, mental, or psychosocial resident outcomes related to noncompliance cited at F726 should be investigated at the relevant tags, such as abuse, quality of life, and / or quality of care. All nursing staff must also meet the specific competency requirements as part of their license and certification requirements defined under state law or regulations. Many factors must be considered when determining whether or not facility staff have the specific competencies and skill sets necessary to care for residents' needs, as identified through the facility assessment, resident-specific assessments, and described in their plan of care. A staff competency deficiency under this requirement may or may not be directly related to an adverse outcome to a resident's care or services. It may also include the potential for physical and psychosocial harm. As required under F838, Section 483.71, the facility's assessment must address / include an evaluation of staff competencies that are necessary to provide the level and types of care needed for the resident population. Additionally, staff are expected to demonstrate competency with the activities listed in the training requirements per Section 483.95, such as preventing and reporting abuse, neglect and exploitation, dementia management, and infection control. Also, nurse aides are expected to demonstrate competency with the activities and components that are required to be part of an approved nurse aide training and competency evaluation program per Section 483.152. Competency and skills and techniques necessary to care for residents' needs includes, but is not limited to, competencies in areas such as resident rights, person-centered care, communication, basic nursing skills, basic restorative services, skin and wound care, medication management, pain management, infection control, Identification of changes in condition. Cultural competency. Staff competencies in identifying changes in condition. A key component of competency is a nurse's CNA, LPN, RN ability to identify and address a resident's change in condition. Facility staff should be aware of each resident's current health status and regular activity, and be able to promptly identify changes that may indicate a change in health status. Once identified, staff should demonstrate effective actions to address a change in condition, which may vary depending on the staff. Who is involved? For example, a CNA who identifies a change in condition may document the change on a short form and report it to the RN manager, whereas an RN who is informed of a change in condition may conduct an in-depth assessment and then call the attending practitioner. These competencies are critical in order to identify potential issues early, so interventions can be applied to prevent a condition from worsening or becoming acute. Without these competencies, residents may experience a decline in health status, function, or need to be transferred to a hospital. Not all conditions, declines of health status, or hospitalizations are preventable. However, through the Facility Assessment Section 483.71, facilities are required to address the staff competencies that are necessary to provide the level and types of care needed for the resident population, considering the types of diseases, conditions, physical and cognitive disabilities, overall acuity, and other pertinent facts that are present within that population. Furthermore, per Section 483.95, facilities must determine the amount and types of training based on the facility assessment. We also note that the curriculum of a nurse aid training program must include training on recognizing abnormal changes in body functioning and the importance of reporting such changes to a Supervisor Section 483.15, 2B2 Roman 4. Therefore, facility staff are expected to know how to identify residents' changes in conditions and what to do once one is identified. Facilities may adopt certain tools to aid staff with these competencies, as these tools have proven to be effective. For example, the Agency for Healthcare Research and Quality (AHQ) has training modules for detecting and communicating resident changes in condition. https://www.gov/professionals/systems/long-term care/resources/facilities/Pete Safety/LTC Module 1, HTML. Also, Interventions to Reduce Acute Care Transfers Interact is a program with several resources aimed at improving staff competencies in this area. https://interact2net/tools v4 Staff may inform surveyors of the tools they use to help show evidence of the required competencies. However, merely stating or referencing the tools is not enough on its own to verify compliance. Staff must also demonstrate that they possess the competency to use the tools in a manner that accomplishes their purpose of aiding to effectively identify and address resident changes in condition. Cultural competencies. Cultural competencies help staff communicate effectively with residents and their families and help provide care that is appropriate to the culture and the individual. The term cultural competence, also known as cultural responsiveness, cultural awareness, and cultural sensitivity, refers to a person's ability to interact effectively with persons of cultures different from his or her own. With regard to healthcare, cultural competence is a set of behaviors and attitudes held by clinicians that allows them to communicate effectively with individuals of various cultural backgrounds and to plan for and provide care that is appropriate to the culture and to the individual. The following resources are intended for informational purposes only. the National Center for Cultural Competency, https://nccc.georgetown.edu/index.html, the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare, developed by the Office of Minority Health in HHS, https://www.thinkculturalhealthhhs.gov/pdfs/enhanced clause standards blueprint. PDF. Note: references to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services and were current as of the date of this publication. Demonstration of competency. Competency may not be demonstrated simply by documenting that staff attended a training, listened to a lecture, or watched a video. A staff's ability to use and integrate the knowledge and skills that were the subject of the training, lecture, or video must be assessed and evaluated by staff already determined to be competent in these skill areas. Examples for evaluating competencies may include, but are not limited to, lecture with return demonstration for physical activities, a pre- and post-test for documentation issues, demonstrated ability to use tools, devices, or equipment that were the subject of training and used to care for residents, reviewing adverse events that occurred as an indication of gaps in competency, or demonstrated ability to perform activities that is in the scope of practice an individual is licensed or certified to perform. Nursing leadership with input from the medical director should delineate the competencies required for all nursing staff to deliver, individualize, and provide safe care. For the facility's residents, there should also be a process to evaluate staff skill levels and to develop individualized competency-based training that ensure resident safety and quality of care and service being delivered. A competency-based program might include the following elements. A. Evaluates current staff training programming to ensure nursing competencies, e.g. skills fairs, training topics, return demonstration. B. Identifies gaps in education that is contributing to poor outcomes, e.g. potentially preventable rehospitalization, and recommends educational programming to address these gaps. C. Outlines what education is needed based on the resident population, e.g. geriatric assessment, mental health needs with delineation of licensed nursing staff versus non-licensed nursing and other staff member of the facility. D. Delineates what specific training is needed based on the facility assessment, e.g. ventilator, IVS tracks. E. Details the tracking system or mechanism in place to ensure that the competency-based staffing model is assessing, planning, implementing, and evaluating effectiveness of training. F. Ensures that competency-based training is not limited to online computer-based, but should also test for critical thinking skills as well as the ability to manage care in complex environments with multiple interruptions. Procedures and Probes Section 483.3, 5A34, C. For specific survey procedures, see the sufficient and competent staffing critical element pathway. Surveyors must determine through information obtained by observations, interviews, and verified by record reviews whether the facility employs competent nursing staff to provide care and services in assisting residents to attain or maintain their highest practicable level of physical, mental, functional, and psychosocial well-being. How are staff competencies and skill sets evaluated upon their initial hire and routinely thereafter, and when new technologies/equipment are put into use? Does the facility assessment describe the type of competencies required to meet each resident's needs as required under Section 483.71 Do the competencies of the staff reflect the expectations described in the facility assessment? Is there evidence that staff are able to identify and address resident changes in condition? What are the practices or tools used that demonstrate this ability? Is there evidence of a lack of competency, such as adverse events that could have been prevented, conditions that occurred that could have been identified and addressed earlier to prevent them from worsening, or hospital transfers that could have been potentially avoided if the reason for the transfer had been identified and addressed earlier? How are staff evaluated to determine that they demonstrate knowledge of individual residents and how to support resident preferences? When observing the provision of care, does the nursing staff demonstrate necessary competencies and skill sets in accordance with current standards of practice? For example, if the resident requires a manual lift for transferring, do staff demonstrate knowledge and skill in the proper use of the lift and perform the activity in a safe manner? The use of techniques and skills that maintain or improve the resident's physical, mental, or psychosocial functioning as identified through required assessments and the care plan, such as, but not limited to, the following. 1. Providing mobility assistance, such as assistance with walking and transferring. 2. Assisting with activities of daily living, eating, bathroom needs, mobility, bathing, oral care, incontinence care, dressing, etc. 3. Providing care to residents with communication needs and ensuring that devices are utilized per the care plan. 4. Demonstrating knowledge about residents' condition and behavior and when to report changes to the licensed or registered nurse. Determine how agency/contract staff have been evaluated to ensure their competencies and skills to care for the facility's resident population. Potential tags for additional investigation, section 483.3 5A34 C. If there are concerns with staff skills and competencies, it may be necessary to review the facilities assessment as required at F838, section 483.71 to determine how competencies are evaluated. Also, review the facility's process for assessing these competencies and skills and addressing staff performance for the effective application of knowledge and skill in the practice setting. It may also be necessary to review the training requirements at section 483.95. Key elements of noncompliance. To cite deficient practice at F726, the surveyor's investigation will generally show that the facility failed to do the following. Ensure the licensed nurses and other nursing personnel have the knowledge, competencies, and skill sets to provide care and respond to each resident's individualized needs as identified in his or her assessment and care plan. Deficiency categorization. Once the survey team has completed its investigation, analyzed the data, reviewed the regulatory requirements, and determined that noncompliance exists, the team must determine the severity of each deficiency based on the harm or potential for harm to the resident. Examples of Level 4. Immediate jeopardy to resident health and safety includes, but are not limited to, a resident sustained a serious injury that required hospitalization and surgery, resulting from a fall from a mechanical lift due to an unsafe transfer by one staff member. When interviewed, this staff member stated that she was not familiar with how to use the mechanical lift. The facility failed to ensure the staff was competent to operate the equipment. Staff did not demonstrate competency in maintaining the airway of a resident with a tracheostomy when it became obstructed by a mucus plug. Staff were unable to act immediately to the situation, resulting in the resident experiencing a respiratory arrest. Staff did not have the necessary skills to adequately meet the needs of the resident, resulting in a life-threatening situation for the resident. A new resident was recently admitted to the nursing home with a diagnosis of diabetes. Upon interview, several staff stated that they were not familiar with using this new blood sugar monitor. As a result, the resident's blood sugar levels were inaccurate and not reliable. The levels continued to fluctuate from very high to very low, and in each case, the amount of insulin administered to the resident was adjusted based on these results. As a result, after 3 days, the resident went into diabetic shock and was hospitalized. The facility failed to ensure that licensed nurses had the skills and knowledge to detect changes in a resident's condition. After the nurse's aide notified the nurse on duty that the resident has swelling in her feet, the nurse determined that the resident has 2+ pitting edema and documented the finding in the medical record. No further action was taken. The nurse did not review the medical record, which identified the resident's history of congestive heart failure (CHF). The next day, the resident's edema increased. The nurse notified the attending physician but did not inform the physician of the resident's history of CHF. The nurse did not conduct any further assessment of the resident, secure orders from the physician, or document a request for intervention from the physician. On day 3, the resident experienced respiratory distress and was admitted to the hospital with CHF exacerbation. The inability of the nursing staff to conduct a thorough assessment and to recognize the signs and symptoms of CHF resulted in heart failure and placed the resident at risk for serious harm or death. Examples of level 3 actual harm that is not immediate jeopardy includes, but are not limited to, an increase in facility acquired stage 2 pressure injuries was noted over the past 2 months for residents with darker pigmentation. When interviewed, several nursing staff, including the director of nursing, stated that in residents with darker pigmentation, staff cannot identify pressure injuries until the skin is no longer intact. The facility failed to provide staff with the necessary skill set to identify and prevent pressure injuries and meet the resident's needs. A resident who usually gets up at 6 a.m. and eats breakfast in the dining room every day has been getting up at 8 a.m. for the past few days. When interviewed, he says he doesn't want to eat breakfast and just wants to sleep. Staff have been letting him continue to sleep throughout the day. When interviewed, they said they think he is just tired, and this went on for several days. The resident then began to decline to eat dinner and seems confused about his whereabouts. The nurse stated she thinks he is just tired and continues to let him sleep. In the morning, the resident is falling in and out of sleep, is incoherent, and has a fever. The facility orders a hospital transfer, where the resident is admitted with a high fever and a positive lab result for a urinary tract infection. A 78-year-old with a diagnosis of hypertension, peripheral vascular disease, diabetes, and CVA cerebrovascular accident receives anticoagulant therapy. The resident developed a nosebleed. Since the resident is on anticoagulant therapy, the MD was notified, and an order for PT/INR was ordered and obtained. The inner was noted to be elevated, requiring the resident to receive an injection of vitamin K. When staff were interviewed, CNA-1 stated that 2 days prior she had noted the resident's gums were bleeding during oral care and thought that maybe he just needed his teeth cleaned, but she did mention it to the nurse. CNA-2 reports that the resident had a medium black terry stool the night before, but she became busy and forgot to report it to the charge nurse. The facility failed to provide staff with the necessary skill set to identify residents at risk for bleeding related to anticoagulant therapy. so therefore the facility staff did not meet the needs of the resident. An example of level 2, no actual harm with a potential for more than minimal harm. That is not immediate jeopardy includes, but is not limited to. Resident did not have pacemaker check performed via telephone due to lack of knowledge by staff on procedure. Level 1 severity, one does not apply for this regulatory requirement. This concludes the reading of Appendix PP. Regulation Section 483.30, tags F710 through F715.